So we're going to start by talking about traumatic brain injury, and I'm just going to mention a few things about it. You get two basic types of traumatic brain injury. Open brain injury, where the skull has actually been cracked and the brain is exposed, and closed head injuries, where on the outside you don't see anything wrong, but on the inside there's been damage to the brain. And it varies in severity, and it's in neuropsychology, we have accepted three categories, in neurology as well: mild traumatic brain injury, moderate, and severe traumatic brain injury. Now, while neurologists and attorneys and so on always ask of us to indicate whether it's mild, moderate, or severe, the fact of the matter is somebody can have even a mild traumatic brain injury and it can severely affect their lives, depending on the nature and where the head injury is. So, for example, somebody with, executive function difficulties, it might be mild overall, but if you can't plan and monitor, and if you're socially inappropriate and so on, you're going to really struggle to keep your job. So, although we write in our reports whether it's mild, moderate, or severe, you always need to explain how that impacts a person's life. That's why we're neuropsychologists, because we're looking at how it affects the entire person. And one doesn't always, but sometimes you have a coup and a contra coup injury. And it typically happens if, in this picture, you see this ball hits this person. And where it hits, the skull moves and the brain bumps against it. That's your coup injury. But as it swings over, the brain hits the other side, and it's your contra coup injury. So we'll often see, if you're doing an assessment, that you'll have, sometimes it's quite obvious, there's a cut or a bruise or something on the one side. And you can test that person, you can see the functioning in that area of the brain has been affected. But then sometimes, exactly on the opposite side of the brain, there are functions there that have been affected as well. Then you know it's a contra coup injury. And whenever you're testing somebody, you need to think to yourself, what is on the opposite side of the brain to that area that got the primary impact? And then make sure you also test for contra coup injuries. All right. So there are three different ways to classify severity of brain injury. The one is looking at loss of consciousness. The other one is looking at the Glasgow Coma Scale, and the other one is looking at post-traumatic amnesia. But each of those are problematic, and we need to understand what the problems are with that. Loss of consciousness is not always a good indicator of whether a person has suffered brain injury or not. We tend to lose consciousness if the brain stem has been damaged in some way. For example, if there have been rotational forces in the brain. Let's say the person was driving and they were looking sideways, and the next moment they were hit and their brain swung back like that, and there were rotational forces, they're more likely to lose consciousness then, because the brain stem is being twisted. So they can have quite a mild brain injury and still have loss of consciousness. So your loss of consciousness is not always a good indicator of traumatic brain injury. You can also find that the person could have had, let's say, a stroke, and there's a bleed in the one area of the brain, and while that might be quite a serious matter, they might not lose consciousness. So loss of consciousness is a fair indicator, but you've got to realize where its limitations are. The Glasgow Coma Scale, similarly, is useful, but you have to understand what the limitations are. Now, with the Glasgow Coma Scale, I'm sure you know this, you measure eye-opening, verbal responses, and motor responses. The whole of the Glasgow Coma Scale is out of 15. Eye-opening is 4 out of the 15, verbal responses 5 out of the 15, and motor responses 6 out of the 15. And if you look up how it works, you'll see that there are various things done to the person to see if they will respond. For example, will they open their eyes spontaneously, or will they only open their eyes if there's some pain applied to them? And usually you'll find in the hospitals, the medical staff all test Glasgow Coma Scale, because they're all trained to test it. So one often you'll see it in ambulance reports, you'll see it in the hospital notes, it's regularly measured. And to a large extent, it's a useful tool. Usually when a person is found, so for example, if the ambulance has found the person, or the person arrives at the hospital. Usually your first measure of the Glasgow Coma Scale, they look at what that measure is. And if it's between 13 and 15, it's normally classified as a mild traumatic brain injury. If it's between 9 and 12, then moderate. And if it's 8 or less, then it's severe. And if it's 8 or less, then the person's completely unconscious. But there are problems with the Glasgow Coma Scale as well, because you don't always know how long has the person, let's say it was a motor vehicle accident, how long has the person been lying there before they were found, before the first Glasgow Coma Scale was taken? And the other problems with it is sometimes people are intoxicated. Sometimes they've been taking drugs, and it affects their alertness and their wakefulness. The other thing we have to look out for is, was the person sedated? You know, quite often an ambulance would come, they'll sedate the person. And then their Glasgow Coma Scale, when they arrive at hospital, is very low because they're not responding, they're not opening their eyes, and so on. So you've always got to look for the notes where they're sedated, try and get a time of when's the first time that the Glasgow Coma Scale was noted. The other thing is, sometimes people have to be, you know, they have to have the oxygen, and there's a tube down their throat, so then they can't give your verbal responses automatically. But what is normally scored then is, instead of, they'll score the eye opening, they'll score the motor response, but in terms of verbal response, they won't give a number for the verbal response. They'll just say T. Then you know that they were intubated. Okay. Then we get the other measure, which is post-traumatic amnesia, which is also problematic in many ways. What post-traumatic amnesia is that if a person has had brain injury, there's often a period where they're not fully alert, they're not fully orientated yet. But there comes a time where they know where they are, and they can remember things from moment to moment, and they can remember things from the previous day. Now, if the nurse is in a hospital, again, assuming the person's in hospital, if the nurse is in hospital, asked every day and made a note of it, does this person know where they are? Do they remember things from the previous day? Then if they made a note of it, you'd be able to know when their post-traumatic amnesia ended. But they usually don't. So if you see your patient 2 years later, you need to try and work out how long their post-traumatic amnesia was. And the best way to do that is you ask the person, when is the first time that you became aware of being in hospital and that you had been in an accident? Sometimes people become more aware and then they drift off into a semi-coma again and become more aware and drift off. But you want to find that point where they realize where they were and what had happened. And people tend to remember that very well because it's an emotional thing. You know, it's very traumatic to realize that you've been in a car accident and you're in a hospital. So people tend to remember that. And once you know when that time is, you can then compare, you ask them, where were you at that time? They're not going to know what the date was or anything like that, but they will remember where they were. Were they in a hospital? Were they in a step-down facility? Were they back home? And you can then look at your medical notes and try to determine where they were at that stage. And depending on the level of post-traumatic amnesia, or the length, rather, of post-traumatic amnesia, you can also work out whether it's moderate or mild or severe. And to get that classification system, you can just look on the Neuropsychology SA website. It does have that classification system there. So if you can determine when the post-traumatic amnesia ended, and you can determine where they were and the length of post-traumatic amnesia, that is a far better, more reliable measure of injury, severity of injury, than your loss of consciousness and your Glasgow Coma Scale. Okay. Now, if you're assessing a person who's had a traumatic brain injury, you really have to understand the brain very well, because you have to understand which areas were injured and how that might have affected the person. But you also need to think about the age of the person. And remember, we spoke about children. We said there's a certain age where children are less vulnerable to the effects of a brain injury than other ages. So you need to think about the age of the person. You also need to try and find out if there were repeated traumas. Have they had a head injury before? Are they an epilepsy sufferer? Do they have, has there been anything else that could make them more prone to brain injury, or that the brain injury would affect them worse than it would another person? And also, was there polytrauma? Was there other trauma besides a head injury? If there's been a lung injury, you need to think about whether there was a period of hypoxia, where the person wasn't getting enough oxygen. And that's probably the most important other polytrauma question. But you need to find out what else might have influenced them. And then also you need to consider whether there was alcohol abuse and how that would have affected the person's functioning. Now, when we think about traumatic brain injury, we tend to think of motor vehicle accidents, of people being shot in the head, of people being hit with things like hammers and baseball bats and things. But you do have your less common source of TBI, like electric and lightning injuries. And they have a slightly different, I want to call it flavor to them. And blast injuries, which we don't have a lot of. I think in South Africa, unfortunately, we have a lot more bullet wounds than we do have blast injuries. So I want to say something about bullet wounds quickly, that what tends to happen with a bullet, if a person is shot, when it hits the skull, it goes through the skull, but then it starts to tumble. And as it tumbles inside of the brain, it does a lot more damage than just one would think of a bullet just going straight through. So one does have quite extensive damage. Are there any questions about traumatic brain injury before I move on to something else? Yes.
Would concurrent maybe more than one concussions also add up as a brain injury?
That's a very good question. Would concussions add on to each other? Yes, they do, and I should have mentioned that. Concussive head injuries, your first concussive head injury is not going to really affect you. By a third concussive head injury, you can start seeing it on the neuropsychological tests. So one does need to try and, there's a lot of work going into educating people really, and sportsmen and their coaches and so on, about concussive head injuries, and to be so careful about concussive head injuries. And you also, if you have a concussive head injury, there's a certain period in which you should rather stay away from doing sport, because if you have a second concussion in that time, it could have very severe consequences. It's called second impact syndrome. It doesn't happen to everybody, but every now and again, you'll get someone who had a concussive head injury and then another one, and the brain swells and the person dies. So it can be very, very serious. But yes, concussive head injuries, they impact on each other over time. That is why with boxers, for example, they become more and more neuropsychologically damaged. Their speech is affected, their processing speed is affected, their reasoning skills, abstract thinking, all these things are negatively affected.
Doesn't often see.
Now let's talk about imaging. Don't know about you, but I never really learned very much about imaging when I was studying psychology. But in the field of neuropsychology, you're often receiving imaging reports. And there are a couple of things that you need to know about imaging. I'm going to explain to you the difference between a CT scan and an MRI scan. The CT scanner looks more or less like that. And it's very quick. It takes 5 minutes to do a CT scan. So it's very good for emergencies. If the doctors need to very quickly know where there's a big hemorrhage on the brain, they can do a quick CT scan. It's also less expensive than an MRI. But the person does get some radiation exposure. So you don't want too many CT scans being done. And you don't really want a CT scan done on a young child. And certainly not on a pregnant woman. With a CT scan, if you have metal implants of some sorts, that's fine. It's not a problem. But it can't accommodate very large people, like people who are over 450 pounds, which relates to about 204 kilograms. So you can see this bed area is actually quite narrow. So they can only accommodate people of a certain size. The good thing about it is that it seldom causes claustrophobia, which the MRI tends to do. And I'll talk about that now. So this is what the MRI scanner looks like. What you immediately see, it looks very similar, but the MRI is a much deeper machine than the CT scan. and that is also why you tend to feel a bit more claustrophobic when you're inside of it. It uses a very powerful magnet and has pulsing radio waves. So it makes this doof, 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 doof sound. And every time it's making a sound, it's switching on and off and on and off and on and off and on and off and sending these radio waves out. So it's noisy. But the benefit of it is that it gives very much more detail, higher definition detail of what is going on in the brain. I'm going to show you the pictures of them now. It also takes longer, so if it's an emergency situation, you can't do a quick MRI. It's much more expensive. But the good thing is that there's no radiation exposure. So, for example, a pregnant woman would more easily be able to have an MRI. But you can't scan people who have metal implants or even tattoos or pacemakers. And if you, for example, have a bullet lodged in you, then it will dislodge the bullet. There was a time I thought it would pull it right out, but it actually doesn't. But it can dislodge the bullet, and that in itself can cause damage. And of course, as I said, one does tend to feel more claustrophobic because it's right here around your head, and it's noisy, and it's actually very distressing. But if you look at the two scans, the quality of the scans that you can get, you can see this MRI is much clearer. So the CT is fine if you're picking up anything big, like a big hemorrhage or a tumor, big tumor. But the MRI is much clearer. And as technology is advancing, the MRIs are becoming even more clear. So let us look at what you need to think of if you're dealing with a CT scan. The first thing, you'll know you're looking at a CT scan if the skull is white, okay, because of the density of it. And the other thing to remember, if you're ever looking at a CT scan, look, we're not qualified to read CT scans or MRI scans, but still, if you see one, it's just good to know what you're looking at. And remember that left is right and right is left. So you need to imagine that you're viewing the person as if you're looking up from their feet. Usually, with a normal, it's not for a normal CT scan, the ventricles are quite distinctive. Here are the ventricles over here. This scan is a slice this way, okay, and you're looking at it from the top. So here are the ventricles, and they should be quite clear. And the third ventricle needs to be visible, and here's your third ventricle here, and it needs to be there along the midline. So one of the things the radiologists look at is, has there been a midline shift? And this is quite a good indicator. So this is a very normal brain, so there's been no midline shift there. The third ventricle is in place. The basal cisterns here, you often read in reports that talk about the basal cisterns are patent. These are the basal cisterns there. So the basal cistern is a fluid-filled space around the back of the midbrain. Blood clots or swelling of the brain may cause this to become narrowed or not visible at all. So that they look to see if they can see it. If they can't see it, then maybe there's something that is a space-occupying lesion, or there is a swelling or something that is pushing the brain outwards. The frontal horns of the lateral ventricles over here are symmetrical. The one side needs to look like the other side pretty much, with a septum between them in the midline. So that's a nice normal looking CT scan. So let's look at an abnormal one. You can see these yellow dots down here. That's the true midline where it's supposed to be. And immediately you can see that the frontal horns have been shifted over to the left. Remember, this is the left and that's the right. So it's been shifted over to the left. And the third ventricle, you can hardly see now, or you can't see at all. It's also, if you look for the basal cisterns, you don't see them here. So you know there's something that is happening here that is pushing the brain over across the midline and causing it to be squashed. If you're looking at diffuse axonal injury, something that you need to remember with diffuse axonal injury is that, well, two things really. Our neuropsychological tests are much more sensitive in picking up diffuse axonal injury than the MRI scans are, and certainly the CT scans are. But if you have particular hemorrhages, these little hemorrhages that are at the interface between the gray and the white matter, those are very good indicators that there was diffuse axonal injury. And the reason for that is because the gray matter is more dense than the white matter. So if there's an acceleration-deceleration accident, the gray matter tends to slide forward, and it then stretches the white matter, causing diffuse axonal injury in the axons. Okay, but you know the axons make up the white matter. But while that is being stretched, these little capillaries that also run alongside them and feed them also get stretched and they break and they bleed. And that's why you have these little particular hemorrhages there where the gray matter meets the white matter. So here you can see one. There would be the gray matter and the white matter under it. Here would be gray matter and white matter that side. Here's another one because there's gray matter here and white matter running next to it. So you see that. So if you see in a report they talk about particular hemorrhages, you know there's probably a diffuse axonal injury. However, there might still be diffuse axonal injury without the particular hemorrhages. Okay? And that is where our tests also come in. Now, it's often a characteristic of diffuse axonal injury that there are numerous particular hemorrhages, but no evidence of brain swelling or midline shift. So you won't necessarily have a midline shift or any brain swelling, but still have these little hemorrhages. Okay. Now, cerebral contusion really means bruising of the brain. So in this CT scan, for example, this is colored in for our convenience, but this is what it would look like on a CT scan. Here you can see this area of bruising, contusion, this gray area, and the white areas within it are areas where it was bleeding. This is just colored in so you can see it a little bit more clearly. Now, when it comes to Alzheimer's patients, the MRI scans and CT scans are very useful in trying to diagnose that as well. But again, our tests pick it up Alzheimer's much earlier, years earlier, than it would on a brain scan. But still, one of the things that they would look at is the hippocampus. And this here is your hippocampus. Now, this is a normal brain. This is a severe atrophied brain. Here's your hippocampus over there. Now, if you look at that hippocampus compared to this one there, you can see how that one is atrophied. So when brain cells die, they shrink, leaving more space around the brain. Now, you know that the hippocampus is responsible for forming memory and storing and organizing information for memory purposes. So it would make sense that if somebody has Alzheimer's, it's the hippocampus that's affected first. But what is also then affected is the entorhinal cortex, which is this area here. Again, this is a normal entorhinal cortex. Here it is atrophied. Okay. And the entorhinal cortex is responsible for memory and navigation. And then the third area that one looks at is the perirhinal cortex over there. Again, here's a healthy perirhinal cortex. Here's an atrophied one. And the perirhinal cortex is responsible for object perception, memory, and associations. Now, just have a look at these two pictures again. These are the ventricles over there. These are more or less the normal size of ventricles. They often, most of the time, they are exactly the same size, but our brains are different, just like our personalities are different and our fingerprints are different. So in this person, the ventricles aren't exactly the same, but they are within normal size. Now, you compare it to these ventricles that are very much enlarged. The reason the ventricles are enlarged is because the brain has been atrophied, so the brain cells have shrunk, leaving more space in the middle of the brain, which then fills with cerebrospinal fluid. So that is why we have these enlarged ventricles. But this would be further along in the Alzheimer's process. Early on in Alzheimer's, you would just see the atrophy of the hippocampus. You would see that first. Then over time, you'll get the atrophy of the other areas and then general atrophy of the brain. And you can see where these gyri and sulci are, that there's a lot of atrophy in this brain. Okay. So let's look at the MRIs of a person with multiple sclerosis. Sorry. With a person with multiple sclerosis, you have these white spots within the white matter of the brain. So you can see there's one, there's one, there's one, there's one. What you also often see, which you don't see here, is you normally see like a blush of white, just a white blush over there, which is also often a sign of multiple sclerosis. I've seen many MRI scans of people with multiple sclerosis, and some people can really have a lot of white spots. But you can also have, I must also tell you, brains with white spots where there is no multiple sclerosis. Okay, some people just have white spots in their brain, and they're perfectly normal. So the doctors try and work out where is that line where now they can say it is probably multiple sclerosis compared to not. And sometimes they wait and rescan the person in about 6 months' time to see if there is appearance of more white spots. Brain tumors are, this one is very clear on the MRI. You can see this big white spot over there. This brain tumor, you can see, isn't having a mass effect. If something has a mass effect on the brain, it means that it's pushing the brain aside. And some tumors will do that. As they grow, they push the brain matter aside. But some tumors infiltrate the brain matter, in which case it doesn't have a mass effect. So if it has a mass effect, then you will start looking at midline shift and just things getting out of proportion. But if there's no mass effect, then you're not going to have any sort of midline shift. And this is a very large tumor, but it's not causing mass effect.
So is mass effect the movement?
Mass effect is where it's where something is pushing the brain out of the way. It's growing inside there and pushing it out of the way. So one doesn't always see a midline shift, but sometimes you'll see the, you've got the ventricles, and you've got the various ventricles and the whole ventricular system. They often look to see where the areas are where the ventricles are supposed to be quite spacious, and they look to see if those appear much smaller and narrower or disappear altogether. Then you know also there's likely mass effect. When it comes to tumors, there are specialists that know exactly what, the radiologists as well are partly specialists in trying to understand what type of tumor it is. But then, of course, you have the oncologists also have to look at what type of tumor it is. Because some tumors, they actually just leave there because they're not doing any harm, and it would be more harmful, or there's a greater risk of harm, by operating on the brain and trying to remove it. Sometimes they'll treat it with radiation, but radiation also has negative effects on the rest of the brain. So you can only do so much radiation, and you're also, the negative aspects of it are outweighing the attempt to treat it. And then, of course, sometimes they will just operate and try and remove it. Sometimes it's quite well defined. It can just almost be sucked out. But other times, especially if it's infiltrated the brain, it's much more difficult to get out and very risky as well. And the doctors also, the neurologists and neurosurgeons, have to think very carefully about how do they get to it, depending on where it is. Do they go through the nose? Do they go through the eye? Do they actually make a hole and go through the skull? It's very tricky and very risky and very interesting as well. So how it affects us is we just need to be aware of this. I mean, we're not going to be treating anybody with tumors, but we need to, if we see a CT scan, we need to be able to know what we're looking at and whether it's a tumor or something else. Okay. Now, PET scans, also known as positron emission tomography, they're the ones that have these, they're very colorful. And it goes from maximum to minimum levels of blood flow. So on a PET scan, maximum blood flow would be white. Okay, you don't see any white here. Minimum blood flow would be blue. So you can see these areas here have minimum blood flow. The green has a little bit more. The red has a little bit more. Okay, so they're really looking at blood flow in the brain. And that could be important for various reasons. You know, that a tumor is not going to have blood flow within it, for example. Now, a functional MRI is the one where the person is awake and you're doing certain activities, and you can actually see how the neurons are being activated within the brain. So this is now a flat picture because of the nature of it, but usually if you're looking at a functional MRI, you see it's changing all of the time. These colors change and so on, indicating where there's activation in the brain. And where that is particularly useful is in research, really, where you're trying to see, if a person does this, which parts of the brain are involved. Then a very new type of scan that one gets now is a diffusion tensor imaging. Now, most hospitals and so on don't have that yet, but it allows mapping of the diffusion process of molecules, mainly water, in biological tissue, in vivo and non-invasively. It reveals abnormalities in white matter fiber structure and provide models of brain connectivity. I'm going to explain to you the way it was explained to me, which made sense to me. If you imagine you take a glass of boiling water and you put a tea bag in it, and you just leave it, you don't touch it. Slowly, the tea will diffuse into the water, and it will diffuse more or less evenly away from that tea bag and into the water. Now you take another glass, and with boiling water, but you put some straws in it, and you put your tea bag in. The tea is going to tend to diffuse into the straws, up into the straws, okay? So it's not going to just diffuse evenly as it would if there were no straws there. Now, the diffusion tensor imaging works similarly to that. So where the white matter tracts are, there's a diffusion into these white matter tracts so they can track it more easily. The colors are added later. I thought it would be so nice if they could have these beautiful, colorful images, but the colors are actually added later by the person doing the analysis. Okay. And the main application is the study and treatment of neurological disorders. It's rapidly becoming a standard for white matter disorders. You can imagine, because it's really looking at the white matter tracts. But the other thing I learned recently is that it's not all that accurate. So if you see tracts there, they don't necessarily look exactly like that. So surgeons can't open up the brain and expect it will look exactly like that. It's just an indicator. I'm sure this will improve over time as our technology gets better. So let's look at the electrical activity of the brain. Now, you get many different types of brain waves: beta, alpha, theta, high delta, deep delta, and they each have their own pattern, zigzag pattern. So because you do need to know this, you need to know which one is theta and what does it do, and which one is delta and what does it do, and so on. So I've just made up a silly little mnemonic just to help you, but you're welcome to make up your own, okay? So we've got bouncy beta. Okay, so the beta one, which is this one here, okay, up, down like this, this is the one, if you're functioning on that brain wave, it is when you're awake and excited and ready for the day. Alpha, the alpha wave, here it is over here. I've called them affable alpha, and it's when you're relaxed or in a state of light meditation, a little bit more dozy. Then you get theta. I've called him daydreamy theta. Here's the theta wave over there. It's when you're daydreaming or you're in a deep meditation. Okay, it's when you're not noticing what's going on around you and people are talking to you and you don't even know it. Okay, it's when you're very relaxed. And then delta, the delta wave, which is this one over here, is when you're sleeping, and I've called him dozy delta. Okay, so you need to remember which one is for which. Okay. Now, EEGs are what they use to measure brain waves. That's what it looks like. You've got these little probes stuck all over your head. It's only on the outside, it's not on the inside. It records the electrical activity along the scalp. And it measures voltage fluctuations resulting from ionic current flows within the neurons of the brain. It records the brain's spontaneous electrical activity over a short period of time, and it's recorded from multiple electrodes placed on the scalp. I'm going to show you now where they are placed. And clinically, it's used for the diagnosis of epilepsy, coma, brain death, and sleep disorders. So this is how they're typically placed in the brain. Okay, you can see this person looking forward. This is the top of the head. There's their nose. There's one ear. There's the other ear. So each side of the scalp has a letter to identify the lobe. and a number or another letter to identify the hemisphere location. So electrodes positioned over the frontal, temporal, and parietal and occipital lobes are represented by the corresponding letters. Okay, so this would be a frontal, this would be occipital. Odd numbers, 1, 3, 5, and 7, refer to the left hemispheres. So here you get the 3s and 5s and 1s and so on. And even numbers, your 2s, 4s, 6s, and 8s, refer to the right hemispheres. There's 8, 4, 4, 6, and so on. And Z refers to an electrode placed on the midline. So this is frontal lobe on the midline. This is parietal lobe on the midline. Okay. Now, your EEG printout looks more or less like this. And so with each little electrode, it has its wave. And so these are the different waves that are from each electrode that is placed on the skull. Now, as you know, as I mentioned, one of the reasons one has an EEG is to test for epilepsy. And we get focal seizures, we also get generalized seizures. Your normal EEG will look something like that. Your partial seizure, partial or focal seizure, in this picture, there's a little seizure over there, will look like this. You can see part of it is disturbed, but not all of it. And your generalized seizure looks like this, where the whole brain is being affected. You'll see all of the little lines are disturbed. Absent seizures look like this. And a petit mal epileptic fit looks like this, with waves and spikes. Grand mal looks like this. Here's the start of the grand mal seizure. And this is a grand mal seizure during the jerking phase. Any questions about EEGs? Again, we don't need to read EEGs. We don't need to understand exactly how they work, but you do need to just have some idea of how it works and how to recognize the patterns. All right, so let's move on to sleep and sleep pathologies. I'm going to go through this fairly quickly, but we're nearly finished. This is our last section. This is what our brain waves look like when we're awake, when we're sleeping lightly, during REM sleep, during deep sleep, and cerebral death looks like that, flat line. Okay. So let's hope we don't get there anytime soon. Okay, and we have sleep cycles. Now, I know you know this, but I'm just going to go through it anyway. This is when you're awake. Stage 1 is a low voltage mixed frequency. Deeper into sleep. Stage 2, where there are sleep spindles and K complexes. Stage 3, mostly slow waves. Stage 4, slow waves. And then you start to come out of it a little bit again, but you don't wake up. You're there, at that stage, you have REM sleep. Okay, so you're almost awake, but you're not. And then deeper sleep again, and then REM sleep, and then deeper sleep, and eventually you wake up and your sleep is finished. Okay. Something you must understand about during REM sleep is that your muscles become paralyzed while you have REM sleep. And that becomes very important in understanding sleep disorders. So I'm going to get to that in a moment. Now, one sleep disorder that many of us suffer from is insomnia. And there could be various reasons for that, so I'm not going to go into that. Restless leg syndrome, I don't know if any of you have ever experienced that, where you feel you can't sleep because you've got to move your legs. They just get really irritable and you have to move them. Sleep apnea is when you're not getting enough, you tend to stop breathing. And you wake up with a shock because you haven't been breathing, and it disturbs your sleep. And I just read some very interesting research in this week about sleep apnea and how people who have sleep apnea are more likely to form false memories. And if you think about how sleep and memory and so on works, you know that during REM sleep, that is when our memories become consolidated, and it moves from the hippocampus to the rest of the cortex. And if you're having disturbed sleep, then those memories don't get properly consolidated. So if you're having sleep apnea and you keep waking up, you're probably not getting proper REM sleep. So those memories probably aren't being consolidated correctly. So it would make sense that those people would be more prone to having false memories. Now, narcolepsy, I find an extremely interesting field. Remember I said to you, during REM sleep, our muscles become paralyzed. Okay, so now there's a reason for that, because when we dream, in our minds we are very active, and if we had to physically carry out those actions when, we're going to be walking around and beating up our husbands next to us, or, we're going to be acting out on it. So our muscles become paralyzed, and that's very normal. That's the way it's supposed to be. But things can go wrong. Okay, for example, you get people who sleepwalk. Okay, where they do get up and they walk around. It's because their muscles weren't paralyzed. Then you get sleep attacks, like that. Do you want to? Okay, sure, Paul. I want to talk more about this in a moment. Yes.
Sleepwalking fall under narcolepsy?
Sleepwalking doesn't fall under narcolepsy, no. But I don't think it's really listed as a disorder.
Yeah.
But it would make sense if you think that it must be a malfunctioning in that natural paralysis.
And it happens in that REM sleep just because the muscles are paralyzed.
That is my understanding. But that one would need to look more into that. But that's my understanding of it.
Sure.
Yes.
What about sleep terrors with children? Is there that brain in with that? Where they just wake up completely terrified without remembering it at all the next day?
I don't know much about sleep terrors, so I can't really comment on it. But what I should imagine happening is they're just very, very bad nightmares that would send the heart rate up and get, the adrenaline pumping. And well, look, most of us don't remember our dreams anyway, so it would make sense that even if you had a terrible dream that you're not going to remember it, what would cause a sleep terrors, that I suppose that would, one would need to go into.
It's very hard to wake them while they're experiencing sleep terror. They're not fully conscious at all. They're awake, but they're not conscious.
Okay.
Does maybe fall into that also the neuroses, like the anxiety? Because when I assess, then I tend to ask about sleep terror.
I can't really comment on that either. I don't have enough knowledge on that.
What about sleep talking?
Sleep talking, I should imagine, again, I'm now just speaking of my understanding of how the brain works, is probably also that, not a full paralysis of the muscles, that you would still talk in your sleep, because you don't always talk in your sleep, and yet often in your dreams you are talking. So it's probably a similar version, just a milder version of sleepwalking. That's what I think, but one would need to look into it carefully.
False memories mean they're inaccurately collected then to give inaccurate memories, not gaps in memories where there's loss of memory.
False memories would be where the person remembers something as being real that isn't actually real. So to them, it very much feels their memories don't reflect reality. Okay, so you get sleep attacks where the person, we normally have a process whereby we fall asleep. But with a sleep attack, the person just suddenly falls asleep, like this. And it's obviously very dangerous because they could fall asleep while they're driving, they could fall asleep while they're up on a ladder. So people with sleep attacks cannot drive, and there are certain things they may not do. Cataplexy is where you'll be wide awake and everything's going fine, and suddenly all your muscles become paralyzed. Wrong time of the day, wrong association, but your brain gets it mixed up, and then suddenly you become paralyzed and you fall down. Hypnagogic hallucinations, on the other hand, are when you're dreaming, but you're actually awake. So you have these images in your mind and so on, as you do when you're dreaming, except now you're awake and you're busy doing something else, and suddenly you have these, what they call hypnagogic hallucinations. It's just the system going wrong. And then sleep paralysis, which is the one that I find extremely interesting, and it's highly common, that you become paralyzed, or you are still paralyzed after you've woken up. So you'll get people who tell you that they will sometimes wake up and they can't move. But what makes it particularly interesting is that it tends to be associated with certain other things. There's a sense of intense fear, or a sense of doom, impending doom. There's a sense of another presence with them or approaching them. There's often a feeling of being pressed down on the chest. And there's a cultural interpretation of the presence in the room. And I've attended some very interesting presentations once on these two Egyptian doctors who were going around country to country and looking at the cultural impact of this. So, for example, in the sort of British area, the people would, the fear they have, the presence they feel is the old hag. Now, I don't know the old hag, but it's apparently something that they really, really fear. In other cultures, it would be other things. In America, he's associated with UFO abductions, that they think these are UFOs. And people that I've spoken to who experience this, colleagues and so on, as I said, it's very common, who experience it, they associate it with the, that little man? Tokelos, the little Tokelos. So, and of course, one can understand the fear because you're paralyzed, you can't move. And it's just a very interesting phenomenon. There's this pressure on your chest, there's a feeling of a presence in the room, and it's very culturally defined. And it only lasts for a few minutes, not even that, maybe even just a few seconds, and then you wake up fully and you can move and everything's fine. And it's just the mistiming of the sleep function.
And also, some people would think it might be poltergeist or something like that.
Yes. And there are people very close to me who told me she's went. Oh, and this is the other interesting thing. It often happens when you sleep in somebody else's house, when the sleep environment is different. So I've had people very close to me saying, that house is haunted because I went to sleep there and I could feel there was this thing nearby me, and I said, well, what did you do? No, I couldn't do anything. I was so scared. I just lay there, but not, So it's just a very interesting phenomenon. It's something I'd love to do more research on, what particularly about the Tokelos and, people's perceptions of it.
How would that fall into that whole concept where people sometimes say that they dream that they have to get away from a situation and that they can't run, can't get away from it?
Now that's interesting. I've never really put those two things together, but you're probably right. It probably has a lot to do with, because you're paralyzed, you can't move. So that you're also aware of that in your dreams. You're running away, you can't get away, because physically you actually can't move. Where this has also become quite prominent, I saw something once on TV about people that got up in the middle of the night, say they were dreaming, and went and murdered somebody. And said they don't remember any of it, they were walking in their sleep. And this whole thing came up of, to what extent were they aware? Can you be dreaming and you're not paralyzed and you actually get up and act out what you're dreaming? So it becomes, it's a very interesting question. I want you to say a quick note, because one can't think about sleep without thinking about memory. Remember that a person has to have REM sleep to have memories consolidated. So if a person is not sleeping well for whatever reason, their memory is going to be affected, negatively affected. So if you think of a young mother with a young baby that's waking up every hour or so, and you think about how they say, those first 6 weeks just went past in a blur, I can't remember anything from it, it's probably because those memories didn't get a chance to get consolidated. And the other quick thing I want to say about that is that if you're studying, and I might have mentioned this before, so forgive me if my memory's not all that good. If you, most of you are studying, I hope you're studying really hard. Remember, if you're writing an exam or something like that, sleep on it first. Some students, and give this advice to if you're working with people who are studying, some people prefer to study till late at night and then sleep and then go write an exam. Others prefer to sleep, wake up early and study and write the exam. The one who sleeps after they've studied has an advantage because that information is being consolidated. The one who doesn't sleep between the time they've studied and written the exam are at a disadvantage because they haven't had that time to consolidate the information. Okay, just something to bear in mind. Okay.
So if someone has a lifelong bad sleeping pattern, they'll probably have sketchy memory as well.
They would have, yes, they would. If they suffer from insomnia or they have sleep apnea, you will probably find that they have sketchy memory. And it's not only because they're tired in the day. It is also, but that could also be a component of it. It's because those memories aren't being consolidated.
Sketchy versus
Yes, sketchy versus false, yes. Yeah. Remember when most of our memories are very unreliable, very, very unreliable. Because when the information is stored, only certain aspects of it are stored. And when you remember it, only certain aspects of it are remembered, and the brain makes up the rest.
Even if you sleep well.
Even if you sleep well. Even if you sleep well. Your brain makes up the rest. And this is why you can have two people that experience exactly the same thing, and they'll remember it differently. And this is why eyewitnesses aren't very reliable in court, because your brain makes up, it fills in the gaps for you. And the other thing is, every time you think you remember something and you store it again, it gets restored and it is prone to error every time. So if it's something, a big event in your life, and you tend to talk about it a lot, every time you remember it and talk about it, and it gets restored with errors. And you remember it later again, you talk about it, it gets stored with errors. And that's why when you caught a fish and it was this big, and later it was this big, and later it was this big, or you just remember these details, somebody else will say, but it wasn't that way. It wasn't that way at your wedding, it wasn't that, but you remember it that way. And your memories are real, but they don't necessarily reflect reality as it was. So you can't say you're lying, because that's how you remember it. This is what you need to read today for this period. And remember, I said to you right in the beginning, we come to a time where there's a lot less to read. There's one tutorial where there really isn't that much to go through. This is it. Okay, so you don't have any major chapters to read. There's a little bit of this, a little bit of that. The information is still very important, so do go through it for the exam, but there isn't that much to read. So this coming period is a good time to catch up on if you happen to be falling behind. I'm sure nobody's falling behind. You're all keeping up beautifully. In fact, you're all far ahead of me, and you've read ahead. Okay, so thank you very much for being here. We're going to take our break and have some tea and coffee.